Welcome everybody. Today I'm going to talk about oxygen utilization in critical care medicine. What is the evidence? The learning objectives of this presentation is going to be describe the historical oxygen utilization in medicine, define the clinical indications for oxygen administration, describe some of the different oxygen delivery devices, review the current evidence regarding oxygen administration in specific patient populations, and then review the current recommendation for oxygenation goals during oxygen administration. So let's start out with a historical perspective of oxygen. So oxygen was discovered in the 18th century by Joseph Priestley, a chemist and physiologist in England, who isolated a colorless gas by heating mercuric oxide. He noticed that when he added this air, it increased the flame of the candle, and it also prolonged life of mice in a closed container. But even Priestley early on recognized that if you gave this oxygen in too high of doses, it could be actually very, very dangerous. Priestley would go on to get, he would be quite a political figure, and he would be ostracized and eventually be thrown out of the England Society of Scientists. Anatole Levasseur was a French chemist that used oxygen in human experiments and actually was the first to call oxygen oxygen. So he actually named the oxygen back in the later 18th century. So this is one of the famous Joseph Priestley experiments that if he, you could see you had candle A, you had the situation A where you had the mouse and oxygen was exposed. And then if you closed off that container and you did not give oxygen, you could see the flame would go out, and thus the mammal in this sense, the rat, would die. If you add oxygen through photosynthesis of a plant, you can see it produces oxygen. And even though you close off the container, oxygen continues to be produced by the plant, and thus the flame in the candle continues to burn, and the mammal survives. Levasseur's respiration experiment was done in his lab, where he actually showed that you could produce oxygen in a gaseous state and actually deliver it to a human being and increase the amount of oxygen above room air. So you could actually produce oxygen in a gaseous, from a liquid to a gaseous state, and thus deliver it to a human being. And this is, again, using the mercuric oxide, showing that if you were able to increase atmospheric air and increase that atmospheric air and deliver it from a liquid state into a gaseous state, you could actually cause fire to occur and thus support combustion also. So you can see these are early experiments where these individuals, Priestley and Levasseur, were the first to really understand, one, what oxygen was, and two, how you could take it from a liquid state to a gaseous state. They also discovered nitrous oxide, not nitric, but nitrous oxide, that was used as a laughing gas and could be used as an anesthetic. Initially, it was used a lot at parties. So you could see here an example where they have a bag full of this nitrous oxide and they're giving it to this woman here, and you can see they're all laughing and having a good time. And this continues today. And this is down in Florida. Nitrous oxide parties are very very prevalent and common down there. And so one could argue that we really haven't progressed much as a society. We're still doing the same things that we were doing centuries ago. So that's a little bit of a historical perspective on oxygen. Often we forget about the history of oxygen, and often oxygen even isn't considered to be a drug. Okay, it's innocuous. It's not used judiciously. A lot of times it's an afterthought. But oxygen is very, very important in clinical medicine. And if you don't use it appropriately, you're going to run into big time problems of escalation and patient deterioration. Thomas Bellows, who is considered to be the father of respiratory care or the father of pulmonary medicine, he developed the oxygen lab, where he could actually, again, take liquid oxygen, make it into a gaseous, and then use it as a way of treating medicine. Historically, oxygen was first used to treat tuberculosis in patients because it was thought that tuberculosis was caused by a lack of oxygen getting to the lung. So in 1798, Thomas Bellows founded the Pneumatic Institution for Inhaled Gas Therapy in Bristol, England. Again, the first use for oxygen was a treatment of tuberculosis. Oxygen supplies and delivery systems were very scarce and very primitive compared to what we would think of now. The first widespread use of oxygen administration occurred during World War I. And again, wars are notoriously beneficial in the terms of promoting the medical community and medical advancements, because you have a large amount of, quote, patients, soldiers and civilians that unfortunately are usually are injured during the conflict. So they were used initially for toxic gas inhalation, especially mustard gas or sulfuric gas that was used that often caused severe hypoxemia and asphyxiation in the soldiers. John Haldane was the first, and you remember the Haldane effect on the oxygen dissociation that causes the curve to go left in alkalosis and in hypothermia. He was the first to develop an oxygen gas mask, where you could actually have a mask, a cone, put on a patient's face that could actually not only deliver oxygen, but also increase the concentration of oxygen by having an oxygen reservoir system. But he also warned against the excessive use of oxygen. Notice that individuals that were given high concentrations of oxygen for prolonged periods of time could could be injured or develop some kind of respiratory symptoms like hemoptysis, etc. Plus, he knew that if there was too much oxygen in the environment, the potential of an explosion or increase in combustion, could occur. This was Haldane's gas mask. Okay, you can see it's hooked up to a primitive, we would call an e-cylinder probably today. It has a kind of reservoir bag and a mask, and then everything is made out of rubber back then because they didn't have plastics. This was the first nasal cannula that was utilized. It almost looks like a BiPAP mask that we would use today, but this was the first. This was the first actual cannula that was used, and again, this is in the early 1900s. And these are some other ones you could see. This is an oxygen catheter. These were very common when I started in the profession in the mid-70s. There was no piped in oxygen, so all oxygen was delivered with a tank. There was no cryogenic type of storage system. This I find interesting, is where you have a cannula, oxygen cannula, with glasses here. So if you had COPD and you needed oxygen, but you also had trouble seeing, you could beat two diseases at, if you were myopic and at the same time hypoxic, you could use your glasses to get oxygen and be able to see. So these are early oxygen administration devices. They're almost all made out of metal or out of rubber because, again, plastics were not available at the turn of the century and up until 1960s, 1970s. This is interesting. Again, this was a lot of times for gas asphyxia and also for pilots when they went up above, as they start losing barometric pressure, they might get what would be considered to be negative pressure pulmonary edema, and they would, pass out, become hypoxic. So this was a 4-person mask that Haldane could use both during aviation, but also if there was some kind of, again, asphyxia situation with some kind of noxious gas or with some kind of, inhalation, carbon monoxide poisoning, something like that. So it really, the history of oxygen use in the critical care patient, you have to understand that critical care is on around that long. It was in the 1950s that first ICUs and blood analysis were developed in Copenhagen, Sweden during the polio epidemic, which hospitals like hundreds with respiratory failures cases. And that, historically negative pressure ventilators were used. It was during this epidemic pandemic, yes, polio pandemic, that the first positive pressure ventilators were used, and there were improved outcomes with the positive pressure ventilators over the negative pressure ventilators, the iron lung being the most classic and the standard negative pressure ventilator. And it really almostly and when the positive pressure ventilators came, may they be the pneumatic ones like a Bird Mark 7, or may they be like Puritan Bennett or Emerson, they always needed some kind of compressor gas in order to work, and that always was oxygen. Some had an air-oxygen mix, others were just a potentially all pure oxygen with ambient air entrainment, like the Bird Mark 7 or the Mark 10s in a sense. But they always involved the use of oxygen to power. So this really excelled the use of oxygen in the hospital community, and especially in the critical care environment. So everybody that came to critical care always got a certain amount, always was placed on oxygen because that was the standard of care. And if you were going to be on a ventilator, you were obviously going to be put on oxygen, just like you are today. I mean, there are not many patients that are in the ICU that are on oxygen, that aren't on oxygen, that are on room air. Almost everybody's on at least 30% or more. 1953, this is in Mass General up in Boston. You can see the polio epidemic that the many iron lungs were being used at that time. Back in the corner here is something called a rocking bed, which I actually got a chance to see early in my career. These beds would, based on how far the bed would descend and ascend, would be, quote, the tidal volume, and how fast they would go would be the rate. And then there would be oxygen via cannula or a mask that would be given supplementally. What interesting was this, trying to draw a blood gas, you couldn't stop the bed in order, when you were drawing a blood gas, that'd be like turning off a ventilator when you'd be drawing a blood gas on a ventilated patient a day. So you'd have to do these blood gases. And I remember when I was drawing one on the patient and I actually hit my head on a monitor. No big deal. They just sewed my head up. And I went back to work. Now, goodness gracious, you'd be out for weeks and weeks. But the rocking bed was very interesting. It was a negative pressure ventilator type of device that used the motion of a bed. And, this was, a pandemic or, that hit multiple children and families, sometimes whole families. And you can see this is a multi-person negative pressure ventilator in the 1950s. Again, not the best way to ventilate compared to what we have now, but this was the state of the this was a standard, the state of the art back into the 50s. And then we started getting to positive pressure ventilators. This is the pneumomotor chest cuirass with a rocking bed. Again, this would use, the rocking bed would help facilitate the tidal volume by just sending the diaphragm up and down. And then you would just negative pressure ventilator which was a chest cuirass. So this would be often what patients would be on during the day, and then at night they would go into their iron lung. Now, the first positive pressure ventilators were very, very huge. They're very similar to the first computers. So back in the early 60s, you had computers that were the size of the room, not like you have now in your phone. And the same thing with ventilators. Yes, angstrom ventilator weighed 500 pounds. It would take some really strong individuals to push it from one area to the patient's room. And then again, everything was piped in. There was no piped in oxygen. Everything was tanks. So, you'd have to be changing these tanks quite frequently in these patients. And you can see, there's no computer, there's no computer elements integrated into these ventilators. It's all solenoids, pistons, needle valves, things like that being used. But again, you can see the device is being powered by oxygen. Emerson post-op, Jack Emerson. Again, this is an early prototype ventilator that used a piston inside that drove the gas with the piston. Almost sound like a vacuum cleaner when it would be given breaths, especially when it gave a side breath. But again, a lot of these devices, you couldn't even adjust the FiO2 from 21% to 100%. You had to change, you had to basically go from maybe 21 to 50 to 100 or 30, 60, 100. There weren't, like now, you can dial in any FiO2 you want. And there's a Puritan Bennett MA1, which was a very, very advanced compared to those two other ventilators we saw. You could dial in any FiO2. You had high pressure limits. You had different flow. You could set a square wave type of flow, inspiratory flow. It had some alarms on it, and then it had a good, nice way of humidifying with the cascade humidifier. You could measure exhale volume. So this, again, was the first ventilator that you could actually dial in precise FiO2, precise oxygen. So if you didn't want to give 100%, you could actually give 55%. That's what you wished. Now, when you look at the clinical indications for oxygen administration, and I teach, the med students a lot of this when it comes to you can kind of figure out somewhat what the pathophysiology of your patient is based on the response of oxygen. Some pathophysiologies will not respond to oxygen because you have loss of alveoli. Other will respond fairly nice, especially if you use higher concentrations where you can have a higher driving pressure of oxygen that drives it across the alveolar capillary membrane through secretions and fluid. So you look at the 5 causes of hypoxemia, you have high altitude, so you have loss of FiO2. Okay, the FiO2 is not, it's still 21%, but it's barometric pressure is lower, so the PO2 drops because you don't have the same amount of oxygen pressure in the air. Okay, that responds very easily to oxygen. You give more oxygen, and the FiO2, the PO2 will go up. Hypoventilation, you lose respiratory drive. There's nothing wrong with the alveolus. Okay, you lose respiratory drive from the central chemoreceptors of the brain, medulla and pons, and all of a sudden you're hypoxic because you don't take enough air in. You put them on a ventilator and their PO2 goes up very nicely because they don't have alveolar capillary disease. They have apnea. Now, when you start getting into lung pathophysiology, you have VQ mismatch, like patients that have COPD, patients that may have pneumonia, where you have a lot of good alveoli and you have some obstructed alveoli. You hyperoxygenate the good alveoli, you get blood, you increase the blood in that alveoli, and thus you increase PO2. Now, when you look at diffusion deficit, like pulmonary edema, interstitial lung disease, you could have some early ARDS. There, you need higher FiO2s because you need to increase the driving pressure. So Patients with diffusion deficit may not do well on 8 liters nasal cannula, but then you put them on 70% high flow oxygen via OptiFlow or Vapotherm, and you can increase their PO2 because you have an increased driving pressure, which then causes the oxygen across the alveolar capillary membrane, which improves oxygenation. So PO2 could be 50 on 8 liters. You put them on 70%, the PO2 is 200. Why? Because Henry's law says the greater the gradient between two pressures, the greater the driving pressure to get across an obstruction. And then the last thing that does not respond to oxygen is a shunt. If you have atelectatic lung, you have complete collapsed alveoli, as you might have in severe ARDS, you can give all the oxygen you want. It's not going to make a difference because you don't have any alveolar surface area for that oxygen to diffuse across. So you have to somehow open up the alveolus and get the alveolus inflated. So the clinical management of oxygen was really focused on the normalization of physiological parameters. Really, more oxygen was better, and everybody in the ICUs or anybody doing resuscitation was always started 100%. Majority of PO2s in the ICU between the 70s and 80s was around over 100. When I started, our goal for PO2s in the ICU was 100. Okay, so if someone was on 40%, their PO2 was 75, you jacked them up to 60%, so you could get that PO2 of 100. That dropped in 1990s to 2015. The goal was to keep a PO2 above 85 because there was strong evidence that oxygen was toxic, especially in high FiO2s for long periods of time, and not more oxygen was better. So it dropped a little bit. It was, and we do know that it was deadly in COPD patients. It took a while before the hospital community understood the concept of hypoxic drive. So many COPD patients died pink, unfortunately, because of the high oxygen knocking out their hypoxic drive. Also, we learned that it was injurious to newborns, that high oxygen concentration to a newly born baby could cause retrolectal fibrillation, which caused scarring of the eyes and caused blindness. So today we are very astute, realizing that too much oxygen, especially in these two patient populations, is not warranted and very injurious, unfortunately. So unfortunately, that there's still high levels of PO2 still exist in ICUs, despite an increase in body of evidence that demonstrates harm. What we do know that it has been known to cause lung disease. If you have FiO2s greater than 70% for 4 days, can cause fatal pneumonia in rats. FiO2s greater than 50% for greater than 7 days can cause alveolar edema in humans. And one thing you can see is patients that have severe ARDS, and you use high FiO2s, you will find that these patients sometimes get worse x-rays, get worse edema, because you're stuck in a vicious circle of giving lots of oxygen to someone who's a poor PO2, but the oxygen itself, along with other types of high pressures, high volumes, not enough PEEP, can cause ventilator-induced injury. It can cause vasoconstriction and absorption atelectasis. You can denitrozize the alveoli and cause it to collapse. And most studies in the ICU have shown that most patients with high PO2s end up dying because the cost of trying to ventilate these patients will cause ventilator-induced injury in the sense by using too high tidal volumes, pressures, etc. Currently, there's been several retrospective studies showing that the harm effects of hyperoxemia, and we call hyperoxemia anytime there's a PO2 above 100. All right, it doesn't have to be 200, 300. Anytime it's above 100, it's considered to be hyperoxemic. Now, we do know that oxygen does cause oxygen radicals, free radicals, that can react with cell components. It can cause a lipid pre-oxidation of the membranes, it increases permeability, it can cause calcium to go into the mitochondria, which is the powerhouse of the cell, and cause damage. Proteins are oxidized and degranulated, and DNA can be oxidized and breakage. So there's a whole plethora of problems that occur at the cell level. You remember, oxygen is an oxidizer. Okay, will cause things like rust. It will cause many harmful effects that occur in the atmosphere, but that will also occur in the human body. So there's a poor rat that's developed hemoptysis after long periods of high FiO2 in a chemical lab. And we do know that oxygen toxicity can cause eye injury, cataract formation, bleeding of the eye, fibrosis. You can get muscular twitching, seizures, and you can have a host of respiratory. So high oxygen itself can cause ARDS in in certain patients. So you got to remember oxygen is a drug and it needs to be judiciously used just like any other drugs. And I think, unfortunately, because it's been used so widespread, a lot of times that concept is forgotten. When I teach nurses and paramedics and med students about oxygen, I really stress that, it's a twofold. If you don't use it wisely, you can cause patients to be hypoxemic. If you don't use it judiciously, you can cause patients to get injured by it, just like any overdose of drug. And you can see here we have a patient, okay, and this is an old slide back in '69 because everybody knows about atelectasis, absorption atelectasis. When you take nitrogen out of the alveolus, nitrogen is a stabilizing gas, and if you put the patient 100% for 24 hours, you can see that in a day, so this is the 15th of February '69, this is the 16th, you can see nothing else. The lungs go down. They go down for 20, they become atelectatic and they collapse because of 100% oxygen. So my rule of thumb is I try to put no patients on 100%. The only time I would use 100% maybe during a cardiac resuscitation for a short period of time, but not on any ventilated patients, because once you put them on 100%, you are now shutting off the alveolus. Even though you have PEEP that can stabilize the alveolus to a point, you're still going to get this absorption atelectasis. Now, when we started talking about evidence, I think it's very important to look at the way we administer oxygen in specific patient populations. So this is very interesting. Individuals that do respond and do, are survivors of cardiac resuscitation have a 1.8 increased mortality if their PO2 is above 300 post-resuscitation. If that PO2 remains high, okay, 57% of those patients are most likely to die compared to with PO2s of 300. Now, this is super hyperoxygenation, but the point being is we should try to turn the FiO2 down to the lowest FiO2 to maintain as SAT as possible, not continue to give a patient 100% after they receive ROS and have been resuscitated. The clinical rationale on this, oxygen radicals may be released when organs are reperfused to distal organs like the kidney, liver, or other gut organs. So these free radicals can be released during reperfusion of the blood flow. In mechanical ventilations, patients with PO2s greater than 100 had twice the mortality than patients that had PO2s of 60 to 80s post 24 hours intubation. Almost every ARDS study has shown that the group, even the ARGNet study, which is the classic one, is that low tidal volume, that group had much lower PO2s than the high tidal volume group, but they had a much higher survival rate. So we learned that the cost of oxygenation may be worse than the actual lower PO2. So we now, are very cognitive to maintain PO2s around 60, SATs around 88%. During COVID, we target SATs around 85%, because again, the cost of oxygenation may be very destructive to the lung. And you can see this is a very busy slide, but it shows you that you can get interstitial injury, you can get cytokine response, you can get a bunch of biophysical injury from shear trauma, overdistension, cyclic stretch. Okay, a lot of times we call this atelectatic trauma, shear trauma, and stuff like that. So again, trying to minimize the pressures, trying to use things like ECMO may save the person from not only the disease process, but the harmful effects of too much oxygen and ventilator-induced other injuries. And this is just, again, showing you the different normal alveolus, what occurs during volume trauma and atelectatic trauma, where the alveoli are stretched and then collapsed, and then what can cause from bile trauma, where because the lung is injured, it releases cytokines, which then cause distal organ injury, sepsis, and other type of reperfusion type of oxidation. Interestingly, in head injured patients, CVAs, traumatic head injury patients, that low flow oxygen increases outcomes compared to patients that are placed on an oxygen mask. So these patients, it's better to give basic cannula therapy. Optimal range is 90 to 94% for CVA patients, 90 to 92 for traumatic head injured patients. And the rationale is that high PO2 may cause vasoconstriction and may lead to intracranial pressures. We learned this when we were using the Lycox, which was a probe that was put in the brain, that if you do things like hyperventilate the patient and blow the CO2 down, you actually cause vasoconstriction in the brain, and you control the CO2, but now you prevent the oxygen from going to the brain, and the brain becomes hypoxically deprivated in the sense. So you got to be very careful that if you have too high a PO2, too low of CO2 in the brain, you can get vasoconstriction, which then causes lack of blood flow to places in the brain. So MIs, almost everybody's an MI gets thrown on an NRB mask. This has been standard of practice for as long as I can remember, the 50 years that I've worked. Okay, it showed that higher SpO2s were associated with increased levels of cardiac enzymes and infarction sizes. There's no evidence that NRB should be used. A basic cannula, keeping these sats again above 90%. Oxygen may cause reperfusion injury to the myocardium and actually then spread or extend the actual area of infarction. So very, very important that if you're going to do, put patients on oxygen after they have an MI, you should use a mild to moderate amount of oxygen, not keep patients on NRB mask for prolonged periods of time. Again, randomized trials in ICUs. This is an Italian study showed that that if you had a lower SAT in the ICU, the mortality of that group was 11%, almost 12. SATs above 97% had a much higher mortality rate. ICU ROC study showed that a 24% risk reduction in patients that have lower SATs. And in the NICU, that if you look at patients that have PO2s of greater than 100, okay, there was increased atelectasis and muscle weak in the hyperoxic group. So again, when you're looking at these randomized trials, looking at oxygen as the variable, the actual, isolated variable, that again, the higher SATs, the higher PO2s associated with worse outcomes in the ICUs and in the NICU. So why do we continue to do this? Now I'm talking to a lot of people here, and they're going to be saying, well, I give oxygen, I give oxygen, I give oxygen. Yeah, I know, we all do, okay? But we got to break the habit. It's just like drawing up blood gas all the time. We have non-invasive technology like capnography and oximetry We don't need to stick someone's artery all the time to figure out. If their end-tidal CO2 is normal and their SAT is 94%, most likely their blood gas is going to be adequate. Old habits die hard. Dyspnea is associated with hypoxemia. Nobody wants to see anybody struggle to breathe. High oxygen administration demonstrated success in World War I victims of gas attack, tuberculosis, and pneumonia. So again, well, there's a lot of literature out there that says oxygen is important, okay, but aggressive use historically of oxygen there was really no measuring tools. Patients were just put on oxygen. Some of them got better, others died, but we really don't know why, because we didn't have ABGs or SpO2 probes, and it basically became the standard of all critical patients. Just became one of those things that this is what we do, and those things are very hard to change. Very, very hard to change. So if you want to increase oxygen carrying capacity in the blood, you realize that oxygen PaO2 is only a small portion, less than 1% of the oxygen content in the blood. You want to maintain a pain airway, make sure the patient's being ventilated, increase blood volume, correct anemia, enhance cardiac output, give only O2 if the patient is hypoxemic, not just because they have low O2 content, because it may not help. They may need more blood or a better pump of their heart, and then treat the reason for hypoxemia, heart failure, pneumonia. If you have something you can treat, and you can do a bronchoscopy, you can cause mucokinesis, you can give Lasix, that's going to be a lot more beneficial to improve oxygenation than giving oxygen. So treat the cause. Now, there's a plethora of different oxygen delivery devices out there. I'm going to go through them. There's the nasal cannula, there's masks, there's high flow oxygen, BiPAP ventilators, and last but not least is ECMO. So low flow oxygen is a nasal cannula. You can run this to 1 to 8 liters per minute. It needs to be realized that you can't really go above 10 liters. A lot of people will want to go above 10 liters, and they'll tell you turn it up. But there's really no oxygen reservoir for this. The patient's oral nasal pharyngeal anatomy is the reservoir, and you can only saturate that too much. And then plus, if you have this hooked up to a humidifier and you turn it, it'll flow up too high, the pressure in the humidifier will build up, the humidifier will pop off, and you will then vent most of your oxygen to the atmosphere. Cannula, very, very good way of delivering oxygen, very simple. About 22 to 40%, depending on what literature you read. It's based on the patient's breathing pattern also. Simple mask, often used post-anesthesia. Again, usually not humidified, should be used short term. You can run this from 6 to 12 liters per minute, and that can give you 30 to 60%. And then you look at the non-rebreathing mask, which again is used, for a plethora of medical emergencies, anywhere from post-cardiac arrest, MI, trauma alert, CO poisoning, etc. This you run at 10 to 15 liters. The idea is to keep the reservoir bag inflated during the expiratory phase. It can deliver anywhere from 50 to 95%. And again, it should be used short term, 2 hours max, because it's not humidified. Plus, if you really need high oxygen percentage, you want to get a device on the patient that you can actually know what the exact FiO2 is. So again, all these are incumbent by 1, the patient's respiratory pattern, and 2, when you're using a mask, how tight is that mask on? Is the patient taking the mask off every second? Because then the oxygen delivery is going to drop significantly. Mid-flow devices, you can use a cannula, can go up to 15 liters per minute. Oxygen pendant, the oxygen mat, this here, the mustache. These here can give you an FiO2 of anywhere between, I would say 24% to about 50-some%. So they give you a higher oxygen than a basic cannula because they have a reservoir system in. These pendant and mustaches are often used in the outpatient scenario in patients that have chronic oxygen requirements because they're somewhat oxygen conserving. High flow oxygen, OptiFlow, Vapotherm, Teleflex. You can deliver an exact FiO2 with these, anywhere from typically 30% to 100%. They can deliver up to 60 liters per minute. They all deliver some form of molecular high humidity, so they help with mucokinesis of the patient. Also, there is some evidence that you do get some back pressure. CPAP with these devices, for every 10 liters that are delivered, for example, with the OptiFlow system, the patient may get 1 centimeter of back pressure. So if Ken Miller's on 50% and 50 liters, he's not only getting 50%, he could be getting as much as 5 of CPAP as a pseudo back pressure. Now that probably doesn't get transmitted to the alveolar level, but it might be enough to stent the airways. These are very, very effective. Unfortunately, sometimes they're not used correctly. They're used for patients that have severe hypoxemia. They're best for mild to moderate, and sometimes they're tried to be used in lieu of BiPAP. They don't facilitate CO2 removal. Ventimask, oxymask. The Ventimask, you can have anywhere from 25 to 50% based on these different cones you can use, adapters. You run this at 10 liters. Each of the, I think it is 24%, 28, 32, 40, and 50%. And these are used for patients primarily that have really tight oxygen requirements, like a patient that has severe COPD, gold standard number 4, 5, in the sense that these would be an exact FiO2, so we don't give them too much oxygen to knock out their hypoxic drive. Because remember, those low flow systems, the FiO2s are various. New device out there, Oxymask, you can deliver anywhere from up to 90% down to 20-some%. You can run it at 15 liters down to 2 liters. I personally don't have experience with this, but I know they are very popular these days because you don't have to change devices. You can go right from a mask to a kind of a cannula by using one system here instead of changing different interfaces. And then obviously we have our conventional ventilators. We have oscillator, we have high frequency percussive, the VDR. We have high frequency jet ventilators that we use in the NICU. And then we have non-invasive ventilators like BiPAP. And that typically your ICU BiPAP devices, you can dial in the FiO2 again anywhere from 21 to 100%, like Philips EV300 or V60. Now, when you start getting into Respironics, ResMed's Loomis or the V30, that's by Philips. These devices, you bleed in oxygen, so the concentration of oxygen is less known because you can go typically from 1 liter to 8 liters with those devices. But conventional ventilators, oscillators, jets, you can dial in exact FiO2s. Far from when we first used ventilators back in the 1960s, where the majority of the FiO2s were either fixed at certain numbers and you didn't have a range, or they could be variable if you use a pneumatic ventilator based on air ambient entrainment. We do have hyperbaric chambers. Okay, these are very, very popular to use for wound healing, deep sea decompression, brain abscesses, and wound healing. We have a lot of burn patients and wound patients in our wound center that use hyperbaric chamber. Here you're going to have multiple atmospheres. So unlike when you go up to Mount Everest, where you lose barometric pressure, in these you add barometric pressure, so you can increase the PO2 not by giving oxygen administration, but by increasing the atmospheric pressure. So instead of the PO2 in the air of 159 at sea level, you increase free C levels, you now have a PO2 of somewhere around 500 at that point. So that's the idea with hyperbaric chambers. Very popular for wound healing today. Not that used as much for CO poison as they were historically. LeBron James, a basketball player who's now in his 20th some year of playing and can play at a very high level for his age. One of the ways that he has muscle recovery is that he often goes in a hyperbaric chamber and facilitates muscle soreness, other kind of injuries, and accelerate those healing much quicker than the average player. He sprains his ankle. Average player might be out for 2 weeks. By using hyperbaric chamber and many other things he does, nutrition, man spends $2-3 million a year on his health in order for him to play basketball. This hyperbaric will help him heal quicker. So he'll be out for 3 games. The average player might be out for 10 games. So let's talk about the future of oxygen administration. Oxygen is now recognized as a dangerous drug if overused. It's got to be used judiciously. We're not saying that we want patients to be hypoxemic. We're not saying PO2 is 40, don't give oxygen. But we're saying if you're going to give it just like any other drug, give it judiciously and only use it in the lowest concentration that gives you the clinical effect. So when I look at ventilators today in our ICU, we have patients as low as 25%. So today, I looked at the ventilator load. We had 30 patients on vents. There were only 3 of them above 50%. The majority were less than 50%, and many were on 30% or less. So again, should be only prescribed in documented hypoxic patients, not as a panacea for all seriously ill patients. Not everybody in the ICU needs oxygen. We must be careful oxygen administration does not suffer the seesaw pendulum effect. As I said, we don't want people hypoxic because we know the ills of hypoxemia. You can cause tissue death and you can cause death in general. And high concentrations are indicated for specific emergent situations. I'm not saying you don't put anybody on 100% for short term. You first intubate them, you can put them on 100% until you get their sat up, from the intubation or the resultant hypoxemia. But once you get a good sat, turn the FiO2 down. Don't leave it high. So the current practices for oxygen utilization and critical illnesses, we want to target an SpO2 of 90 to 94% for most patients, target an SpO2 of 88 to 92% in ARDS. All right, so you can see, and as I said, during COVID, we were 85%. Again, we don't need high saturations, okay? So 90% is fine. I think ACLS says usually keep saturation 94%, and that's the current there. In COPD and pulmonary fibrosis, 88% is adequate in those. Now, 100% in oxygen administration during CO poisoning. So if I get somebody in the house fire, we're going to give them 100% until we can drive their carboxyhemoglobin down. For those patients, that's indicated because they have a process that requires 100% oxygen. But once their CO level gets below 10%, then we usually cut the oxygen down. Target 90 to 92% for CVA, traumatic brain injury, MI, patient populations. And then again, use a high FiO2 the patient to stabilize resuscitation. I don't want you to leave in here and say, well, we don't put anybody on 100% oxygen. That's not what I've said. Again, judiciously used. And target the FiO2 and SpO2 with assessment, making sure that you're looking at the causes of hypoxemia. So you don't want to use oxygen as a mask of hypoxia, because this is what happens too, is I'll have a patient that's on 50%, their PO2 is 50. I increase their FiO2 to 70, their PO2 to 70. I'll have someone says, well, their PO2 is better. Well, yes, their PO2 went up because I increased the FiO2. But when you look at their PF ratio, it's still 100. So oxygen itself never really kind of treats the problem unless you have a hypoxic state, like being in a gas chamber or in a high altitude, or maybe CO poisoning. I could say oxygen does maybe heal that process. But most processes, oxygen is supportive and it should be used as understanding that. And you don't want oxygen to mask the problem. So if you're atelectatic and you keep on increasing the FiO2 and the PO2 eventually gets to where it is, you haven't solved what is the cause of the atelectasis or the hypoxemia. So we should always be really thinking about how can we treat the cause of the hypoxemia, not just using oxygen as the magical drug. So again, ending this presentation, untreated hypoxemia and hyperoxemia are both harmful. All right, both of them cause a plethora of problems. If not addressed judiciously and expediently, you're going to have problems. The former is much feared, but not uncommon. The latter is common and under-recognized. So again, we fear hypoxemia because we know the cost of hypoxemia, but we often don't recognize the harmful effects of hyperoxemia. I hope I've given you enough information to kind of make you to think that, oxygen is a drug, and if not used correctly, it's going to have a whole gamut of problems. Utilization of oxygen therapy should be administered with specific clinical endpoint targets. We should never administer oxygen without having a target SpO2. So when our providers order ventilators or any oxygen device in our institution, they have to put a target SpO2. So we know exactly where we are targeting our oxygen concentrations. And then finally, we as respiratory therapists play a pivotal role in determining the best oxygen administration practice. Let me tell you, I teach all levels of caregivers, from attendant pulmonologists, critical care intensivists, fellows, residents, med students, nurses, respiratory therapists, respiratory therapy students, paramedics, EMS, EMTs, etc. Okay, I can tell you there is an underappreciation for oxygen administration, all those groups, and often there's a lot of confusion. So we as respiratory therapists need to use it judiciously. We need to be the person that sets up protocols. We need to be the profession that makes sure that our patients get the oxygen they deserve, but not too much of it. So if you have any questions, this is my contact information. You can gladly email me. You can gladly give me a call. And I hope you've enjoyed this presentation. I know oxygen isn't necessarily, the most dynamic, pretty, thing out there for respiratory therapists. But I think I've shown you, if not used judiciously or, correctly, it can either one, lead to deterioration, or two, it can lead to long-term problems.